Imagine you're an athlete, right? You push yourself, maybe taking a hit, got an injury, a strain, a bruise, something you figure will just heal up. But what if, instead of just healing, your body kind of goes rogue and starts growing bone, like actual bone, but in a place it absolutely shouldn't be. Not a fracture, not a tumor, just this unexpected bone. That's the fascinating, sometimes pretty baffling world of Myositis Ossificans, MO for short. And this deep dive, well, it's all about unpacking the mysteries of MO, what it is, why it happens, how doctors figure it out, and what it actually means for getting back out there, especially if you're active. Our mission really is to cut through the jargon, get to the surprising facts, the insights from the source material, and give you a real shortcut to understanding this. So let's start with the basics. What is Myositis ossificans really? Essentially, the sources tell us it's a benign, so not cancerous, isolated lump of bone. And it forms in soft tissue, usually right inside skeletal muscle. It pops up quite a bit in active people, athletes especially. And while there are different types, we're really focusing today on the traumatic form. That's the one you often see after sports injuries. Could be internal muscle damage, like a bad strain or tear, or, external trauma, like getting hit hard.
Yeah, and it can be quite the diagnostic puzzle, especially early on. What's really intriguing is that MO can look remarkably similar to much more serious conditions. Things like myosarcoma, which is a soft tissue cancer.
Wow.
And this isn't a new problem either. Doctors were debating this back in 1905, first thinking it was inflammatory. But even then, they noted how much it could resemble, malignancy. It's always been a bit tricky.
And here's something from the sources that really surprised me. We think of traumatic MO following a clear injury, right? And that covers maybe 60 to 75% of cases. But get this, up to 40% of MO cases might develop without any obvious history of trauma.
Exactly.
That kind of throws a wrench in things, doesn't it? It's not always that big ouch moment. And we tend to see it more in males, particularly in their 20s and 30s.
Mm-hmm. And when it does show up, it has favorite spots. Large muscle groups, the quadriceps femoris, the big muscle on the front of your thigh, that's a really common one. Somewhere between 9 and 20% of significant quad injuries might actually lead to MO.
9 to 20%, that's quite high.
It is. You also see it frequently in the brachialis muscle in the arm and the adductor muscles, the ones on the inside of your thigh.
And I love these specific terms the sources mention. They're almost historic, like rider's bone, if you're an equestrian and get it in the adductors.
Right.
Or shooter's bone for the deltoid muscle in the shoulder.
Yeah.
And even ballet dancers might get it in their calf muscle, the soleus. Often in the thigh, it follows a quadriceps contusion, basically, a really bad bruise. It's like the body's way of highlighting exactly which muscles we've been overdoing, isn't it?
It does seem that way sometimes. So, okay, moving from the what to the why. Why does this happen? Well, the exact pathophysiology, the precise mechanism, it's still not completely nailed down, which is fascinating in itself. But the leading theory involves a kind of miscommunication after injury. You have these cells called fibroblasts. They're like the body's repair crew, usually building connective tissue.
Yeah.
After an injury, instead of just patching up the muscle, they seem to get signals to differentiate or transform into cells that build bone and cartilage instead.
So they switch jobs, essentially.
Kind of, yeah. And key triggers seem to be specific signaling proteins. Things called bone morphogenic proteins, BMPs, like BMP2 and BMP4, and another one called transforming growth factor, or TGF. Think of them as biological switches. If they get flipped incorrectly after trauma, boom, you start getting bone formation where you shouldn't. And the inflammation that naturally follows an injury involving things like prostaglandins and cytokines seems to fuel this process too, this heterotopic bone formation.
Heterotopic.
Yeah.
Just meaning bone in the wrong place.
Exactly. Bone forming outside the skeleton where it doesn't belong.
So the body's healing response goes a bit overboard or gets misdirected. But here's a really cool fact from the source. It's something that helps doctors figure this out. Unlike a tumor, which might grow outwards from a center, MO develops in a really specific pattern from the outside in.
That's right. The peripheral rim ossifies first.
And that signature, that pattern, it's like a fingerprint that helps distinguish it from something more serious, like cancer.
Precisely. It's a critical diagnostic clue. And you can actually watch this progression on X-rays over time. In the early stage, say within the first 4 weeks, you might just see some faint calcifications starting.
Barely visible.
Could be, yeah. Then, in the intermediate stage, maybe 4 to 8 weeks, it becomes much more distinct. You see that characteristic well-defined edge. And after 8 weeks, you're in the mature stage. The bone is clearer, more solid on the X-ray.
Okay, so let's connect this back to you, the listener. You've had that sports injury, you're thinking, it's just a bad strain, a deep bruise. And initially, that's often what MO gets diagnosed as.
Yeah.
You start the usual conservative treatment.
Right. Ice, rest, the standard stuff.
But then it just doesn't get better like it should.
And this raises the important question. When should you or your doctor really start suspecting MO? It's usually when the pain, the stiffness in the joint, or problems with function, like, you can't bear weight properly. If it's in your quad, just linger way beyond the expected time frame for a simple strain or bruise.
So persistence is key if it's not clearing up.
Exactly. And during a physical exam, there'll typically be localized pain, tenderness right over the injury site. And clinicians need to be really careful to check for any signs of neurovascular compromise, making sure that growing bone isn't pinching nerves or blood vessels. That's critical.
Okay, so suspicion is raised because things aren't healing normally. To actually confirm it's MO, what imaging tools do doctors turn to? How do they get that peek inside?
Right, imaging is crucial. It usually starts with standard radiographs, x-rays. They're the first step. Good for ruling out a fracture, obviously, but also really useful for tracking how the MO is progressing over weeks and months.
So you can see it developing.
Yes. Early on, like we said, 2 to 4 weeks, maybe just faint cloudy areas, what we call radiopacities.
Yeah.
But by 4 to 8 weeks, you start seeing that classic picture. A well-defined mass, dense around the edge, clearer in the middle. That outside-in pattern.
The fingerprint again?
Exactly. And over months, 6 to 12 months, it might even shrink a bit on the x-ray. And interestingly, Lay and colleagues described different patterns too. Some look flat against the bone, some seem attached by a stalk, others are just scattered within the muscle.
So x-rays are the starting point. What else is in the toolkit?
Well, computed tomography, CT scans can be really helpful, especially earlier on. CT is great at picking up those early calcifications, sometimes even before they're super clear on an x-ray. It shows that zonal pattern really well.
Better detail than x-ray for the bone itself.
In many ways, yes, particularly for seeing the structure and early bone formation. Then there's MRI, magnetic resonance imaging. MRI is generally considered the gold standard for looking at soft tissue masses.
Oh, okay.
Now, it might not show the very earliest calcifications as well as CT does.
Right, you mentioned that. So why use MRI then?
Because it's fantastic for seeing everything else around the MO. It can spot hematomas, track how the mass is evolving within the muscle, see if there's inflammation or swelling. It really helps differentiate MO from other soft tissue problems, often without needing contrast dye.
Got it. So it gives the bigger picture of the soft tissues.
Precisely. And don't forget ultrasound. It's low cost, readily available. Ultrasound is good for telling if something is solid or fluid-filled, like a cyst versus the MO mass. And as the MO matures, you can see changes on ultrasound too. That periphery gets brighter, more hyperechoic, and you can even track blood flow changes with Doppler.
So a whole range of tools depending on what you need to see.
Exactly. Each has its strengths.
Okay, so we've used the imaging, we've confirmed it's Myositis Ossificans. What does this actually mean for getting back to your sport, your activity? What's the road to recovery look like?
Well, the good news is the first line approach is almost always non-operative. Conservative management. The main goals are pretty straightforward. Reduce the symptoms, the pain, the stiffness, restore your range of motion, and ultimately get you back to full function.
And how does that start?
Initially, it involves relative rest. Not complete immobilization usually, but avoiding activities that aggravate it. Plus ice or cryotherapy, maybe some brief immobilization if needed, and compression. Medication-wise, NSAIDs like ibuprofen are often avoided for the first few days.
Oh, why is that? I thought they were anti-inflammatory.
They are, but they also have antiplatelet effects, which might interfere with initial hematoma formation and early healing. So usually hold off for a few days, then maybe use them for a week or two for inflammation control. Acetaminophen, like Tylenol, can be used for pain anytime.
Okay, that makes sense. And what about physical therapy?
Physical therapy is really important, but timing and intensity are key. It absolutely has to start gently. Aggressive rehab too early is a big no-no. It can actually worsen symptoms and potentially stimulate more bone formation.
Right, you mentioned that earlier. So avoid pushing through pain.
Definitely. And interestingly, the sources suggest the role of stretching in actually preventing MO isn't really clear. We don't have strong evidence it helps prevent it.
Huh. What about newer treatments? Anything on the horizon?
There are a few things showing some promise in limited reports, but we don't have strong guidelines yet. Extracorporeal shockwave therapy is one. Hematoma aspiration, draining the initial blood collection, is another. Also, bisphosphonates, drugs usually used for osteoporosis, like IV pomidronate, have been reported to reduce the amount of bone formed.
Nice. There's always a but.
But they're generally not recommended for premenopausal women because of potential effects on future pregnancies.
Okay. And surgery. When does that come into play?
Surgery is pretty rare for MO. It's usually reserved for cases that just haven't responded to conservative treatment after a good 6 months or so. And critically, if surgery is done, the excision, the removal of the bone, should happen only after the lesion has fully matured on imaging. Taking it out too early increases the risk of it coming back.
So patience is vital, even if surgery is needed.
Absolutely vital. But overall, if we connect this to the bigger picture, the prognosis for MO is generally favorable. It's typically self-limiting, meaning it tends to run its course and often resolves, or at least stabilizes, on its own. Most athletes, with the right management, are able to get back to their previous level of activity.
That's definitely reassuring. But you mentioned the rehab can be tricky because there aren't really standardized guidelines or formal return-to-play protocols. It sounds a bit like uncharted territory for athletes.
It can feel that way. There's no single recipe.
So if there's no fixed playbook, what's the absolute key principle for starting PT? You said gentle.
The absolute non-negotiable is achieving pain-free range of motion before starting active physical therapy. You cannot push through pain. That's the foundation.
Okay. And what's a typical timeline look like?
Generally, symptoms tend to start getting better around 6 to 8 weeks after the injury. For competitive athletes aiming to return to sport, it often takes somewhere between 4 and 6 months.
4 to 6 months. That requires some patience.
It definitely does. But the data is encouraging. Simon and colleagues, in one study mentioned in the sources, found 90% of patients were doing light activity by 3 months. By 6 months, 90% were back to their pre-injury level. And within a year, it was 100%. Every single one had returned to sport.
Wow, 100% within a year. That's really positive.
It really highlights that with proper management, the long-term outlook for returning to play is generally very good. And even for those rare cases needing surgery, the outcomes tend to be positive. Orava reported back in 2017 that 30 out of 32 surgical patients successfully got back to their pre-injury competition level.
That's fantastic news.
Yeah.
But it's important to mention, it's not always a perfect story, right? There can be complications.
True. Potential complications, though less common, can include chronic pain that persists even after the MO has matured. And in rare instances, an athlete might find they just can't return to their previous level of sport.
Which really just hammers home the importance of getting that diagnosis right, getting the right treatment, and be really dedicated and patient with the rehabilitation process. It truly is a journey, not a sprint back.
Couldn't agree more.
So there you have it. Myositis ossificans. A pretty unique situation where the body's healing mechanism kind of goes into overdrive after an injury, building bone where it shouldn't, often mistaken for simpler things, but as we've heard, with careful diagnosis, the right treatment plan, and that all-important patient rehab, the outlook for athletes is, well, generally quite positive. It really makes you appreciate the complexity of our bodies, doesn't it? Even when they're just trying to fix themselves.
It absolutely does. And maybe a final thought for you to ponder. Given how incredibly precise our bodies usually are about controlling bone growth, only putting it where the skeleton needs it, what can this over-repair in myositis ossificans teach us? What does it tell us about that really fine line between normal healing and pathology? Especially when we think about other areas of regenerative medicine, how do we encourage healing without accidentally tipping the scales into unwanted growth? It's a fascinating question.